I'm going to start sharing our presentation. Okay, Peter, we are live on YouTube. It's 2 p.m., so we can start.
Well, hello everybody, and welcome to the latest webinar. This is another of the webinars that the Global Platform is hosting jointly with the International Long-Term Care Policy Network and their LTC COVID group. So I'm sure you're familiar with both the Global Platform and LTC COVID, but if you're not, I've just put up their logos and their respective websites, and they're both really networks of academics and experts and stakeholders with particular interests, either generally in long-term care and COVID, or more specifically on low and middle income countries, not just in terms of long-term care, but older people more generally. And today, as you can see, we're going to focus on long-term care, but we're going to be quite specific in that we're not going to talk about long-term care facilities, about care homes or nursing homes. We're going to look at older people who have care needs, but who are living at home with their families or with other people. And clearly, you know, there has been a lot of focus, I know, and certainly in the Global Platform and the LTC COVID on care homes for very good reasons. But we're also aware that there are a lot of people, older people in low and middle income countries who've got moderate or severe levels of care dependency. And the vast majority of those people do not live in long-term care facilities. They're not in hospital. They're living at home with their family members. They're obviously a group who are very high risk in terms of coronavirus because they tend to be very old and they have multiple conditions which also increase the risk, particularly of case fatality. Next slide, please. Again, I'm not going to say very much about this, but I just think it's worth very briefly making the point that clearly things were pretty bad in terms of home care, as I call it, for older people who needed care before the pandemic in low and middle income countries. And in lots and lots of ways you can demonstrate this. Here are just a couple of statistics I randomly grabbed from something I was able to get hold of quite quickly, in terms of clearly we're seeing very rapid social changes, increasing proportions of older people who are living alone. But even as you see in the second number on the slide, living with other family members doesn't necessarily mean that older people have access to care support of any kind, let alone the right kind of care support, which is both sustainable from the point of view of family providers and is effective at meeting their own care needs and sustaining their quality of life. And we know that there are large and growing numbers of unpaid, unsupported family carers, primarily but not exclusively female, and that they receive almost no support from government schemes or organisations outside of the household. So that's what I mean by unsupported caregiving. There's nothing out there to support them in different ways. And this has really become a growing burden of gender injustice in low and middle income countries. And as I've said, there's an absence of infrastructure to wrap around family caregiving to enable aging in place and to provide support and to build the capacity of these family caregivers. Next slide, please. So that was how bad things were, and I'm sure one could talk about many other aspects of home care that were in crisis before the pandemic. I just put up this image here because I think this is what we're talking about now. We're talking about a car crash on top of a car crash, a crisis on top of a crisis. This is not an area that over the last few months I have engaged with as much as I should have done. I've been focusing a lot on care homes and on a number of other issues. And I'm hoping to start getting some broad insights from today's webinar in terms of the inevitably very complex direct and indirect effects on older people with care needs living at home and their families. And to some degree, what responses are we starting to see in terms of changed behaviours, in terms of perhaps specific interventions to support these responses, and where might we want to take those responses in the short-term future? Next slide, please. And so just as a very quick thing to wrap up from my point of view, one of the things I have been doing is talking to a number of different people in Latin America who are involved in different government schemes which try to support care-dependent older people living at home. And clearly a broad set of issues seem to cross-cut these different initiatives. Clearly they're struggling to do what they were doing before the pandemic, particularly given that it's much harder to actually visit homes in person. There has to be more virtual interaction, which can be extremely challenging, especially with poorer families or older people with cognitive impairment. And there's reduced staff availability because of sickness and sometimes, frankly, just because of fear of being exposed to infection through their course of everyday employment. And then, of course, it would be wonderful if these initiatives could be doing new things specifically to address the challenges of the pandemic. And certainly 3 schemes that I've been talking to people about, each of them are trying to do different things in different ways. Some of them trying to find ways to provide safe vaccinations, or to improve engagement with these households in terms of testing for coronavirus and reporting symptoms, or just making sure that family carers for older people are able to stay in touch with health and social services without there necessarily having to be a direct visit. So these are just some examples. So there are many, many, many issues, and I'm really excited that we've got a fantastic panel, and we've got Adelina Comiserero, who's going to be chairing our panel. And, you know, sometimes I sort of introduce people, but I don't think I need to introduce Adelina. Everybody must know Adelina. If they didn't know her, you know, 8 months ago, they certainly must know her through her work with the STRIDE group on dementia in developing countries. And of course, as she calls herself, curator, or maybe I don't know quite. She is LTC COVID. Come on, you know. I know other people have made very important contributions, but you have driven that, and that's hugely to your credit. Before Adelina immediately takes the reins, I'm just going to hand over to Lucas, who is our organizer, and he is going to quickly tell you how this is going to work and how you can ask questions, and then I will hand over to Adelina. Thank you, Lucas. Thanks.
Thanks, Peter. We have 3 different ways that participants can interact with us. We encourage you to do it. You can ask questions on the Q&A session. The questions could be addressed written by the panelists, or also could be answered orally at the end. You can chat with us. And for those who are watching on YouTube, you can also post comments there, and I will be looking at them.
Great, thank you very much for this nice introduction, Peter. I have to confess that I got the idea of starting LTC COVID from you, because you had started Corona older, and I was thinking it would be good to have a focus on long-term care, and also in this case, it's a global focus, including both high-income countries and middle-income countries. And it's been, I call myself a curator, and I did start the website, but this is only working because so many people have contributed with so many areas of expertise, knowledge of their own country's context. And as we're having this very, very important conversation about what's happening to people who are living in the community, I'd just like to stress how little information we have about how the pandemic has affected people who live at home but have care needs, and people who are providing care to these people, and but we know from the very little information we have that the impact has been enormous. Even in terms of mortality in the UK, we can see that people with dementia have died in much larger numbers than they did in previous years, and much fewer of them are dying in hospital. So a lot of families will have experienced things like deaths at home, and how have they coped, how have they managed? And there's so little information and so few studies. And I'd like to encourage everybody who is attending and who is speaking today to think whether you can write about this and submit it to a journal, send it to Corona Older, send it to LTC COVID. We'll be really, really happy to spread the word, because we don't talk about it. It's quite easy for these issues to be ignored and to be unseen. And in fact, we've been able to talk a lot about care homes because it's easy to count, or easier I should say, because it's still very difficult. And in many of the countries in which we're all working, it's extremely difficult, even in care homes, but it is easier to measure the impact in care homes than it is in the community. So this is my little hobby horse. Thank you so much for joining this webinar, and thank you so much to the speakers and Peter for involving me. Our first speaker is a colleague of mine from the Stride Project, Ishtar Govaya from the Caribbean Institute for Health Research at the University of the West Indies. And she's going to talk about COVID-19 and long-term care provisions for older people in Jamaica. The floor is yours, Ishtar.
Thank you, Adelina. May I ask Lucas to stop sharing the current screen so that I can share mine? And in the meantime, just to say thank you very much for the honor of this invitation to speak today at this, this very, very important webinar on long-term care and COVID and older persons in low and middle income countries. So as some of you will already know, Jamaica is the largest English-speaking country in the Caribbean. It has a population of over 2.7 million persons, and approximately 12% of that is of older persons. And just to get a context in terms of COVID-19 and older persons in Jamaica, to date, there are over 8,900 cases in Jamaica, COVID reported cases in Jamaica, and of those there have been 202 deaths to date. As you can imagine, in many other countries, there is a large part of the population is really very fear-stricken in terms of their vulnerability and their risk, and this is particularly the case with older persons. And such fears are intensified by, very recently, we learned of an outbreak, the first bit of news about an outbreak at a care home, over 43 persons infected in this one care home. We can see from the data to date that a large proportion of the cases in Jamaica are of persons who are 50 and older, but even more alarming, such a large proportion of deaths of persons who are living, who have COVID, are persons who are older. And to date, we also know that there is a considerable proportion who have been persons who are living with dementia. And before we start to talk about older persons who are community dwelling, it's very important to understand the diversity of context in communities. So Jamaica is a middle income country. It's classified as an upper middle income country. However, a large proportion of the population lives in informal settlements, and that large portion of the population that lives in these informal settlements, their built environment and their communities are very much not conducive to basic amenities of living that so many take for granted: access to running water, pathways for ease of access. So when we talk about things like wheelchair access and those types of things, those things don't even resonate in those communities because they're not used to physical structures and layouts like that. On the other hand, there is a large proportion as well of certain parts of the country where the housing and the community living infrastructure is much more amenable to the typical types of things that we have in mind when we think about care and caring for persons as they age in place. We know in Jamaica that over 40% of the households have at least 4 household members, and that we also know that there is a considerable proportion of older persons. Over 25% of older persons are actually the only person living in their household. And so this is something really important to keep in mind as we think about care and we think about long-term care provisions for community dwelling persons. These community dwelling persons are often supported by churches, places of worship. Some of you may know that Jamaica has the the Guinness Book of Records listed for having the largest number of churches per square mile. In Jamaica, there are over 1,600 churches. And this is really important in terms of the avenues via which some of these services, such as meals, such as things like respite care, even though they're not officially named respite care, these types of services are provided by these places of worship. And it's important to keep this in mind as we think about where persons are based. Another important component to think about as well is that there are over 58,000 domestic workers in Jamaica that are documented. And of those, a small proportion, over about 5,000, are represented by the Jamaica Household Workers Association. And what we know is that the largest number of employees in this category of workers are actually women who are coming from rural communities and moving into urban communities to provide support to families that need that help. And it's important to keep that in mind, because when we think about the older persons who are left in rural communities, we can understand even more how their access to persons who can provide care is even more limited, particularly in the context of some of these things that we're leaning towards with relying on telemedicine, etc. In Jamaica, there's only a 55% internet penetration. And so that's something, again, important to consider when we think about care. So what are the challenges that are faced by community dwelling older persons? We have these stay-at-home orders for persons who are still working or who live at home. And as I mentioned just now, this is increasingly concerning for persons who are employed in the informal economy. And that's particularly concerning for persons who are self-employed. A number of older persons have been self-employed. They've been farmers. They haven't been represented with things like formal pension plans, etc. Another challenge, of course, is managing information and misinformation. There are a number of persons who are really poaching on the COVID crisis to create paranoia and fear among older persons. There is clearly reduced access to nursing aides and helpers with these limitations in movement. Helpers are domestic workers, and so families have had to stop allowing helpers to come into their home context. And of course, this puts even more burden in multi-generational households on women in those households who are often in the sandwich generation. There's reduced household income, of course. There's the boredom and isolation and loneliness that can happen. And there's also an understandable hesitance in terms of using public transportation and accessing health services. So in the face of these challenges, what has been happening? We've had a multi-pronged response occurring. The Ministry of Health and Wellness has been partnering with the National Council for Senior Citizens, which is based in the Ministry of Labor and Social Security, to do things like putting on wellness webinars. And keep in mind what I was mentioning earlier about the internet penetration and how that's 55% or so. But there have also been in-person events that have moved outside of the clinics, the health clinics, the public health clinics, and have gone into community centers, because they're realizing that they can get more of the older persons who are living in communities to the community centers instead of going into the clinics. There's been a large push for and an increasing investment in training community health aides as well. Over 1,000 additional community health aides have been employed. And then there's also been a telephone line and support service set up for persons who have mental health concerns or needs at this time. Government agencies have also mobilized in terms of their community-based support. So there's a mobile pharmacy service. There's Food for the Poor, working with the Caribbean Council for retired persons to really to get care packages to shut-ins. And then another entity, which is called the Social Development Commission, has been working to provide additional services to elderly in place. Then we have the council, the voluntary council for social services, support services, and that's been providing other types of help, whether it is phone-related services, helpers-related services, or errands. They've been working to get help to persons who are aging in place and living in communities. There have been other efforts in terms of the United Nations Development Program, and they're working with other aid agencies to respond with sanitation packages and with other care packages as well. The private sector has mobilized as well. The private sector, not just in terms of medical doctors, but with the things like telemedicine, but the private sector has also mobilized in terms of, again, care packages, but as well with services, things like banking services. There's a concern that some of these services, even assisting with access, safe and hygienic access to things like the ATM in communities, again, are really relevant, particularly for more urban spaces and less attentive to older persons who may be needing help in rural communities. There have been some community-based efforts as well in terms of grocery delivery services. The Jamaica Constabulary Force, the police force, has been partnering with a private foundation, a hotel foundation, Sandals, to get care packages out as well. And there are other services related to helplines. We need to remember again that older persons with care needs are often living in multi-generational households. And so these multi-generational households can really benefit from all types of help. Particularly when the accounts for these households may be in the name of the older person. So things such as electricity and water, there have been relief packages related to those, government subsidized relief packages, and there have also been packages from the entity itself, which are not, these entities, the electricity and water, are not publicly taken care of. So these are private entities that are owning these utility services. There have been hotline services offered as well through the media. And then finally, I just wanted to highlight work that we've been doing through Stride in terms of how we support older persons and their carers who are living in the community, who have specific care needs. So we've been providing practical support, we've been providing advice and information, knowledge translation, and we've been doing collaboration. So we offer free dementia care consultations, and this tends to be of multiple uses to family members and support services, such as places of work, those offered by places of worship. We offer advice and information in terms of really trying to distill core messages as well, that come from larger entities like the World Health Organization, like PAHO, so that they're in understandable language for persons who are living in communities. And this also relates to our knowledge translation. Sometimes the press briefings can provide really densely packed information. And so our COVID-19 in summary series is really meant to distill core elements of that and communicate that to the community-based stakeholders. And of course, we're really happy to partner with entities such as the National Council for Senior Citizens to do more public messaging. We realize that this type of public messaging and sensitization is a core part of how services need to be transformed for community dwelling persons. And I'll just end there.
Thank you very much, Ishtar. We will have a round of questions at the end, so we'll take them all together. So if anybody's got any questions for Ishtar, please feel free to write them down in the chat. And I'm delighted then to introduce our next speaker who's going to talk about a very different part of the world. So Nathan Poras at the University of Southampton is going to talk about Indonesian elders and adapting to the new routine. The The floor is yours, Nathan. You have 15 minutes.
Okay, thank you very much. This presentation comes from a project which we're holding at the University of Southampton with the University of Atmajaya in Indonesia. And it's an ESRC funded project, and the project is titled Care Networks in Later Life, a comparative study of 5 communities in Indonesia using ethnography and surveys. Next slide, please. Right, and the aims of our project is to develop a detailed comparative understanding of contemporary care needs, care arrangements, and care impacts in Indonesia by conducting in-depth studies of 5 communities and relating our findings to local and national surveys. And as you can see, these are the project members. There are many people who are working on this project. And of course, we started the project at the beginning of, before the pandemic, and we had to put research on hold, but we've started research again, carrying out interviews via WhatsApp and Skype. And this presentation comes from data that we've been collecting in 2 locations in Indonesia and Java. One is in a neighborhood of Jakarta, and the other is in Yogyakarta. Next slide, please. Next slide, please. So since the 2nd of March, Indonesia has changed, of course, drastically. And since then, yesterday when I checked, there was 404,408 confirmed COVID cases in Indonesia since then, where 104,235 confirmed cases in Jakarta and 3,744 in Yogyakarta. So, this is within a population size of 267, more than 267 million people. So it's a very large country. Also, Indonesia is a very, very diverse country. So, so whatever we can say for one small location in Java may not be applicable to other parts of the country.
Sorry, Nathan, sorry to interrupt, but you're not very clear on the microphone. I don't know if you could just get it a bit closer to you.
I'll bring it closer to you. Yep, sorry. Okay, I hope that's better. Okay, so we've seen that in Indonesia, the new normal is also referred to by the acronym AKB or AKB, which stands for Adaptasi Kebiasaan Baru, which translates loosely as adaptation to the new as usual or the new routines. This was because it wasn't very clear what new normal actually stood for, so the term was quite vague. So the term was translated into Indonesian AKB. And since, of course, the 2nd of or the 3rd of March, and it's a very common sight now to see disinfecting streets and checking people's temperatures and when people go into public places. And this has become a very, very common sight. Next slide, please. Okay. There's been a lot of public pressure for people, and particularly older adults, to wear masks. Government and non-government organizations have been donating masks to older adults through various means. Here you see one organization in Yogyakarta who have services specifically for older people. And so here you see a donation being given, masks being given to a headman of one village to provide older adults with masks. Next slide, please. And there's been a lot of many care workers and members of NGO organizations who have been teaching older adults how to wear masks properly. As you can see, sometimes it's even in the middle of the street when people would just put masks on people's faces and teach them how to wear them. Okay, next slide, please. Next slide. Okay, so with all the publicity and warning about the pandemic, some older adults initially were fearful to leave their homes. So this has led them to spend more time, and this is one of the positive things about this, was that it has led them to spend more time with their relatives, as well as being more dependent on them. The positive side of this means that older adults living in larger houses with family members can spend more time with their elders and also find events to do with each other. There's been a lot of encouragement for that. So here's an example of a family celebrating the first birthday of the child, and you can see the grandmother participating in a grandchild's first birthday party during this period. Next slide, please. Here's another example of a family singing hymns rather than going to the church, because the church services were stopped for a while. So they're now spending time at home, more at home. Next slide, please. Okay. But this has also led to some older adults to be dependent on social distancing habits of their own living family members when they move about in public. So when you're dependent on people, and if you're not going out, and of course you're dependent on people taking care of you who do go out, this can be a bit problematic as well, because family members of poor households living in small houses cannot self-isolate if one person is infected, because some people live in very, very small houses in Indonesia. Poor people live in very small, maybe 2 rooms. And there's also an element of stigma associated with COVID-19, and this is something which also has to be studied, and how stigma in fact affects people's care of older adults and of other people, of non-older adults, and how this affects or influences people's decision on whether they want to even go to be tested or not. Older adults may not want to be tested out of fear of being positive, and the stigma and gossip they believe might ensue if neighbors find out they have contracted the virus. There's also the possibility that family carers might make decisions for their elders based on other than health factors. For example, one health worker told us that there was a case of a woman in Jakarta who was tested positive, and her family feared neighborhood stigma and took it back to her own town, her natal town. There she did not receive any treatment, and she didn't recover, and they couldn't even bring her body back to be buried in Jakarta. So stigma does seem to play a role here, and this is something that should be studied in the future. But still many older adults in Indonesia, and this is now referring to these slides, still many older adults in Indonesia do not have a pension. So many, if they can, they still work in the informal sector, selling goods in the markets or in the streets, or are still in farming. And out of economic necessity, they have to go out to risky places. For many older adults, then, it is difficult to maintain social distancing rules in their jobs. And you can see here in the picture, a woman selling, who's a vendor who sells herbs. Those who do work as vendors, as well as their customers, have to wear masks. Hand sanitizer also made available in public places. So in the picture on the right, there's you see a soap, and there's a sign saying, "Please wash your hands before entering the shop." Next slide, please. But as you all know, masks are not the most pleasant items to wear on the face. For vendors who have to wear them the whole day in the heat, they can be suffocating. And they also disturb the flow of communication between people and so on, and facial expressions can't be detected. And as you can see in this picture, the vendor has put the mask on her chin. Again, a very common sight everywhere, I think probably in every country. But you can forgive her because she's sitting in the heat for hours and having to sell and communicate with people. So it's not an easy task. So according to initial interviews with primary healthcare workers in Jakarta, more people, they've noticed that more people and older adults seem to be flouting the rules, and particularly in the poorer areas. And there has been a casualness in wearing masks, as well as an attempt to regain some form of life in public spaces. So there's more people. Next slide, please. Next slide. Yeah. For those who routinely have to have medical checks, the public centers, health centers, can have become frightening places to visit now. Whereas visiting the health center might be a medical necessity, it also exposes the patient to greater risk, so people are left in double binds. Here you have a public health center in Yogyakarta, a primary healthcare center. You can see the signs, the banners outside. They say, the one on top, the green one, says "in your house, stay in your house, COVID-19, stay in your home." The one at the bottom, you can see AKB, remind people of new routine, washing hands, masks, and social distance, and so on. So so people are left in double binds if to go to visit or not. Next slide, please. And of course, seeing medical personnel in PPE, dressed in PPE, might initially be an alienating or distressing experience. One informant expressed how frightening it was to see her doctors looking like they were aliens. And this image is from a health video for older adults. It says, and you see it says, it reads, if you cough or sneeze, cover your nose and mouth with a tissue or arm, and below it, it reads the expression, when outside, wear a mask when outside the house. And if you can see the image of the cartoon of the older adult, the expression on her face is apt. It's a very clear image of how frightening it can be to see somebody dressed like that. Next slide, please. Oh, by the way, there have been many videos made in Indonesia for older adults and for the general public, many cartoon, many animated videos warning about COVID-19 and how to regulate oneself. Okay. Before the pandemic, primary healthcare volunteers visited older adults to monitor their health, and this picture was taken before the pandemic. So this gives you an example of a healthcare worker, of a primary healthcare worker visiting an older adult. The pandemic, of course, has disrupted the ability for healthcare workers to visit their clients at home. Before the pandemic, primary healthcare volunteers, they would visit people in their homes, they would check their blood pressure and provide sugar tests for diabetes, as well as encourage people to visit the local clinic. So there is a gradual attempt at looking after formal care of older adults in Jakarta and in Yogyakarta, at least, and in other parts of Indonesia. But this has been disrupted because healthcare workers can't visit clients' homes. There have been a number of healthcare workers who were tested positive as well in Indonesia. And so one healthcare worker stated that nevertheless, they do make their rounds, but they stand outside now. So like if you look at this picture today, the healthcare worker would not be standing so close, but there would be a little fence and probably standing on the other side of the fence. It is easy to see people who live in smaller and poorer houses because in fact their houses are on the street and are exposed, like you see in this house. The door is open, the window is open, there's a large window in front. This is in one location in Jakarta. But in fact, it's more difficult to see people or to visit people who live in larger houses because their houses are closed. So the volunteers are also now keeping contact with people via WhatsApp. And but again, poor households, not everybody has access to WhatsApp, not everybody has access to the internet even. So there are still people who are not being properly contacted, or they can't be because of lack of technology. And one volunteer in Jakarta has claimed that over the past few months, more older adults now were also spending more time outside in their yards, on the streets, and losing their just the fear. She said that this has also given them, healthcare workers, the ability to actually keep an eye on people not by visiting them at home, but by just walking around in the streets and seeing their clients in the yards or on the streets, and that they take now the opportunity to tell them from a distance to exercise rather than just to sit around. So she also reminds them of the pandemic protocol and other health matters. So there is still an attempt at communicating with older people in Jakarta and in Yogyakarta. So even after there was an initial period of chaos and halting of activities, they've resumed in a new into the new conditions. Next slide, please. And this is a very interesting picture in Yogyakarta. There's also NGOs who are now active again. Again, they had to stop for a while, but now they're active again. This picture of these NGOs do provide also formal care to older adults, and they've reorganized or rescheduled their activities. So with this picture, this is a picture from an NGO called Indonesia Ramah Lansia, which is translated into English, it would be Age-Friendly Indonesia. And they have resumed their activities in Yogyakarta, and they've actually established a school for older adults in one village, where the infection rate is low, and the school teaches older adults about health issues. And the school has also been holding classes again as a trial run since August 2020, and also has been given classes online. And as you can see, people are sitting socially at a distance from each other. And so there's an attempt at resuming activities under the new routine, or under the new period of the new normal period. So there's, it seems then that all the NGOs and the healthcare workers have found ways to reconnect with older adults in Indonesia. And I think that's a very positive sign. And I hope in the next few months we'll have more information, more data from our research project. Next slide, please. Next slide, please. Thank you. That's, by the way, from a health, one of the Indonesian health videos for older adults.
Thank you very much. It's always great to see the graphics that come out from Indonesia. It's always very, very inventive. I'd like to, so as I said before, we'll get the questions at the end. So any questions for Nathan, please put them on the chat box for now while they're fresh in your mind. I think we already have one that I've noted, and we'll make sure to come back to it later. So now we go back to the Americas, and we're going to hear from about Mexico. We're going to hear from Almudena Ocejo Rojo, the Director of the Secretariat of Social Inclusion and Welfare, the government of Mexico City. And she's going to tell us about supporting care-dependent older people living in the community in Mexico City during the pandemic. So we've got 15 minutes. The floor is yours, Almudena.
Thank you very much, Adelina. Thank you all. It's a pleasure to be here. I just sent you, Lucas, I'm sorry. I just recently sent you my presentation. I don't know if I can
you can share
it from here.
Yeah, you can do it.
Okay. In the meantime, some of you might know, but in the Secretariat of Social Inclusion, we have an institute that is the Institute for the Care of Elderly People. And in Mexico City, there's been since 18 years ago, there's been an important program for, income support for the elderly. So that has made this institute evolve through the years. And we do have a large team of people and a huge database that allows us to keep track of elderly people in the city. That sounds very perfect. It is not so much. We have our difficulties with the database and following up, but just to put you in context, we have 1,200 people, women, that are employees of this institute, and they do outreach and field work permanently. And so the next one, please. And so we continue to do these tasks, but now it's moved towards phone follow-up. But however, I'm gonna present you two of the main activities that we have been doing, taking care of the people, elderly people in Mexico City. And I just fast want to, sorry, some of the slides are in Spanish, but I'll translate. This is the Institute for Population Studies in Mexico at the national level. And this is the projection of how elderly people in Mexico City is going to grow. So as you can see now, today, people over 60 years of age comprise 16% of Mexico City population. But by 2030, they will be 21%. Just to give you an example of how the growth rate it's going to be. This institute, the institute that we have at the Secretariat of Social Inclusion, we focus specifically on people over 68 years of age. This is because that was the way it was established from the beginning, to give these people the economic support, like the economic pension, to help them basically with food, to buy food. So that's why we continue to focus specifically on people 68 and plus. So that's the information I'm going to share with you. The next, please. So just in terms of the status of the COVID pandemic in Mexico City, we have at the national level confirmed cases 912,000, and of those 17% are in Mexico City. Now, in terms of the age of the people that have died, at the national level, we have 90,773 people that unfortunately have passed away. In Mexico City, it's 12.7% of those deaths, and people over 60 years of age in Mexico City amount to 61% of the people that have disease. So just to give you a general idea, here is the graphic with the range of age and sex of the people in Mexico City to your right. The next, please. And another general information, this is poverty by age group in Mexico City as well. And as you can see, elderly population is the age group that has the lowest rate of poverty. This is explained by several factors, but one of them is, well, it's still 30% of the population, so it's high, but compared to the other groups of the population, is the lowest one. And this is explained by many factors, as I was saying, but one of them is elderly people being, at this moment, part of that generation that that belong to those eras where are no longer here, which is stability in work. So most of them do have a pension, and most of them had like stable jobs and so on. So this is not the case right now. So we're going to be seeing the effects of poverty in elderly people in 20 years, which might be somehow different. But this is just to give you an example. It's like 30% of the elderly people in Mexico City live in poverty. The next one, please. Okay, so I was saying, I was mentioning to you there are two different activities that we have been conducting during this pandemic. The first one is this one, is the following up on elderly people with no social or family network. This is specifically people that we have, like in this big registry of 750,000 people, the database that we have. It's the people that is not the same as living alone. These people are not only living alone, but they report to have no social or family network. So they are facing the pandemic really alone. So what we did was establish a special program. Also, the follow-up responsibility is in this Institute for the Elderly People. And we assigned 210 people to follow up every week on these elderly people. We have identified almost 6,000 people that are in this condition. So every week, these 210 women that belong to the Institute do follow-up calls and ask them if they need anything. And then if they do need anything, we provide whatever is it that they need. We have provided so far medicines to 2,515 people. As you can see, also food to 907 people, and medical attention. A lot of medical attention is required. We also have 10 doctors. So with all the the health prevention measures because of COVID, but we do attend homes in order to provide the visits. Some of them might be, might be provided over the phone, but if there's the need to visit the people, in person, the personnel in the Institute provides this social service. And some of them want errands. It's the is the lesser proportion, but if they need it, I mean, we are at you know, we are there to provide with whatever they need, because they are people in poverty. This is elderly people that have a situation in poverty, and then they are totally alone. So this is a program or a project, a special program that we established because of the pandemic, but it's going to be staying as one of the regular programs in the Institute, because we have seen that it is very important. In this program to follow up elderly people with no social or family network, we also have engaged one university in Mexico City. It's the ITESM, the Tech University, and right now we have 217 young students. Some of them might not be only students, might be faculty members or just staff from the university that have signed up to be volunteers. So besides 210 people that are following up from INED, we have 217 volunteers. And what they do, these students, we wanted to provide like this also intergenerational combination. So what they do, many of these students, is just we called adopt a grandfather or adopt a grandmother. So since May, they've been calling them all the time by phone and just, be there for them. And it's been a very satisfactory experience, both for the elderly people, but a lot for the students. So this is also a component of this following up on elderly people with no social or family network that is here to stay, because it has been a very satisfactory experience. The next, please. The second, and this is not a program that we have right now. It is our regular work, but in the pandemic we shifted to phone following up by phone. This work is done by the 1,200 women, professional women that work at the Institute. Usually pre-pandemic, we will do home visits all the time, permanently, during the whole year. So each of these 1,200 women have assigned a group of elderly people, and they follow up on these people. And, they ask what they're doing. They provide, care if they need it. They follow up on their family situation, socioeconomic situation. However, because of the pandemic, the visits were suspended, but we have been following up by phone. Now, this has some restrictions because, as you can see, from 70 and 50,000 people that we have in the registry, 330,000 people, almost 331,000 people have phone. This means, or they are reachable by phone. This means that this is the people that we have been able to follow up. And we wanted to also update this registry. This registry has been in a process of updating for the last year and a half, but we took this time to also update the registry in times of COVID. So this has been the number of people we have reached during the pandemic. And what we do is we ask several questions. It's a long questionnaire, and we ask several questions in order to know how they are doing in the pandemic and how the things are going on. So I'm going to show you just fast some of the information. There's a lot of information, and all of them has to be more like systematized, but we just pick some of the information that might be of use or of interest to you. The next one, please. From this universe of 330,000 people, they are older than 68 years of age. 20%, almost 21% have any, one type of disability. A lot of them is physical disability or a chronic degenerative disease. This is higher, of course, than usually is reported, but this is more precise because this is the people that actually are being, called and, follow up on their situation. The next one, please. In terms of if they would like to receive permanent follow-up by our doctors or by our personnel at the Institute, as you can see, 2.5% have reported that yes, they would like to. Most of them are the ones that are in this situation with no family network, obviously, because they don't have anybody, to look for, to take care of them. So basically, reportedly, these 2.5% of these 330,000 people do say, yes, please continue to support us, even if it's not only during the pandemic. The next one, please.
Almudena, you have 3 minutes.
Sure, yes, I will be on time. This is elderly population and work. No, it's work. Almost 2% have reported that they still need to work during these times, and they have not stopped working. 2% of the people that have been reached. The next one, please. But what we ask also is how much do you make per month? And as you can see, it's a very low wage per month. It's usually less of $200,000. And they also need to contribute. Almost 22% of the people that say that they are working right now during the pandemic are contributing to family income. Next one, please. In terms of violence, we have been following up on this very strictly, and we have 588 cases of violence. They report to us. That doesn't mean they file a complaint. 67% only mention that they file a complaint. However, as you know, reporting violence among elderly people is not very accurate, all the numbers, because it used to be generally underreported because a lot of the violence comes also from the family circle. The next one, please. This is interest in participating in group activities. We have 270 groups that provide help. During the pandemic, only of those 270 groups, only 22 have been active virtually. The rest of them have been suspended, but it's 8% of the people say that yes, they would like to belong to one of these groups after the pandemic, if during the pandemic it's not possible right now. The next one, please. This is how life satisfaction looks at the moment. It's a very low report, unfortunately. The next one, please. And this is the last one. And we also are asking, if you have care responsibilities, rather than only asking if you need, to be taken care of, it is if you are taking care of people. So 5% of the people on these 330,000, 5% of them report that they are doing care for other people, and 88% of them are just taking care of them all the time. If you can see between the ratio between women and men, of course, women, as we know, care is always on the hands of women. And the next one, and this is the last one, I promise, because I think it's important to see that one. And as you can see, these elderly people that are taking care of others are themselves, in the range of 70 to 85. So this is something to be aware of, in terms of policy and in terms of the help that we provide to these people. So I will leave it at there. As I mentioned, there's a lot of information. We still need to do more curatorial work on the data, but this is a first, snapshot of what is going on with our follow-up activities at the Institute for the Elderly People in Mexico City. Thank you very much.
Thank you very much, Almudena. And next, we're going to have a presentation from Zia Han. Zia works at the World Health Organization, and she's a formidable driving force. We first met through the World Health Organization policy brief on long-term care and COVID. and looking forward to hear more of her work now.
Thank you very much, Adelina. Great to see all of you, and thank you once again for the introduction as well as the invitation from LTC COVID and the Global Platform. Can you see my slide?
Yes.
Okay, fantastic. Great. Once again, I would like to say that the prior presentations were extremely informative and interesting. So great to be a part of this webinar today. As we all know, global data shows that as persons get older, there is an increased risk of death, with case fatality ratios rising exponentially as age increases. And as we have seen with Mexico City's situation, a lot of the older people are users of NCD services. 75%, according to WHO's survey, 75% of countries that have participated reported that there were disruptions to one or more of the 8 services being presented right now. And as we can see, services important to long-term care, including rehabilitation, palliative care services, management of chronic conditions, are shown to be disrupted in more than 40% of countries reporting partial disruption, with lower middle income countries being somewhat more likely to report disruptions in areas of NCD services. However, the pandemic has had a monumental effect, not just on disruption of services, but also on mental health and well-being of people worldwide. As we can see, the services for mental health care has not been disrupted just for older adults, but also for caregivers who are fundamental in the health and long-term care service provision in the home and communities. This detrimental impact of COVID-19 on long-term care has also affected long-term care service provision at homes and communities worldwide. And as we all know, family caregiver burden has soared with aggravation of existing difficulties for them, such as isolation, emotional and physical burden due to longer hours of caregiving and more. However, the provider side of long-term care has been further disrupted by COVID-19. Peter also mentioned in the chat box, fear of infection. Families are canceling service usage, making it difficult for providers to maintain provision of services and aggravating an already large shortage of long-term care support in home and community settings. And for some business operations of long-term care providers, it has completely stopped making older people that need help beyond family, and for those who do not have family caregiving support, to receive long-term care services at home and in the community. There has also been an impact on case management and coordination services, which are fundamental, as we all know, for integrated person-centered long-term care services. However, there have been difficulties in arranging case conferences, home visits, because people also refuse this due to fear of infection. And in many countries, we know that daycare centers have been closed, putting additional burden on family and aggravating the stressful situation for all. So this vicious cycle has continued throughout the pandemic and expected to continue even after the pandemic, since once again, a lot of long-term care providers will not be there to provide care. And this further isolates, aggravates loneliness and the health impact of older people within homes and community. As Adelina just mentioned, so in July, WHO published the policy brief urging policymakers and authorities to look beyond long-term care facilities and address long-standing challenges across whole of long-term care, take actions to mitigate the impact COVID has had on long-term care, inclusive of services in homes and in the community. So Adelina and I worked day and night, I think, to finalize this with the WHO Global Network on Long-Term Care as well. So it has recommended key actions that should be taken to better the situation and alludes to how countries can no longer neglect fragmentation and under prioritization of those who provide long-term care, as well as who receive long-term care at homes and in communities. Some of the response measures that the policy brief is recommending is the policy brief urges local governments to collaborate with existing long-term care providers, including NGOs, to promote sustainable home visit and long-term care outreach programs. In areas of financing, the policy brief urges to support providers, especially not-for-profit providers that are experiencing loss of revenue, so that they can continue to provide services and survive the pandemic, to continue to provide services after the pandemic. Also enable flexibility in the use of personal budgets, cash benefits, and more. And of course, we cannot emphasize more and more caregivers, as Almudena mentioned in her presentation. When we talk about caregivers, it's also those who are older persons themselves. So supporting caregivers financially is also a fundamental component to maintain home and community care services. Establishing mechanisms to report the number of people who have COVID-19 among those receiving and providing long-term care in community and homes is extremely important. Once again, providing and ensuring IPC standards are met for caregiving within homes to prevent the transmission is once again a component that should be met. And once again, training and decision-making support for long-term care workforce in the community must be ongoing in all situations as well. Continuity of essential services, a must and a must. I see that I also have a typo here, but the emphasis on telehealth and virtual technology has been rising during the pandemic. In terms of internet access, it's difficult in many cases, but also not just in low-income countries, but also in high-income countries as well. And so in terms of telehealth, we think more about mobile technology, but we also try to promote the traditional phone calls that we use without the smartphones. So this is something I think Mexico City is really advancing on, and I would love to have a connection, and so that we can have some best practices that we can touch base on and provide support to other countries as well. And also to consider developing clear COVID care pathways inclusive of home and community-based care, so that continuity of services start from home to primary, to secondary, and to tertiary care. Supporting caregivers, once again, it's fundamental. The policy brief urges again and again to support caregivers and repeats this message within the policy document, as well as any other WHO document provided to support countries in strengthening their community-based long-term care services. And once again, it's in the policy brief. I won't go through all of them, but once again, very important. And also emphasizing psychological well-being of those who receive care, but also provide care. I just highlighted two aspects: encourage long-term care providers on the use of screening tools, review staffing procedures to better manage the burden of care, and seek to reduce the use of physical restraints. Mexico City is also looking into violence, and it's very great that we can provide other countries with that example to support the monitoring of violence towards older people, because it is so very important and under neglected. Although this is not a global product, once again, WHO Regional Office for the Western Pacific region have provided guidance that goes beyond just long-term care facilities. It provides advice on COVID-19 for older people and caregivers in general, advice to caregivers of older people with dementia, self-care for general well-being of older people, and strengthening community-based supports, and encouraging use of ICT, but also encouraging governments to expand and make possible telehealth when the infrastructure is not there. So still many things to do, but I think in terms of community home care, long-term care, it's once again emphasis on the older person who's receiving, but also supporting caregivers to provide care, to look into the burden they have, to look into the fragmentation of services that need to be provided to also the older persons themselves, but also caregivers. And it's wonderful that Mexico City asks the question not on do you need the care, but also are you providing the care, and it's really great, and it will be a great example to other countries as well. Thank you very much.
Thank you very much, Zia, for this excellent overview. And now it's time for some questions, and I'm going to first use my privilege as chair to ask each of you in turn about something that's come up, and I think Peter also identified in the chat box, which is the role of fear in people denying or not accessing services and reducing them. And what do you think may have been good approaches, if you can think of some, in your countries or in countries you're aware of, to try to counteract that? So I'm going to take it in turn. So we're going to start from Ishtar, who's had a chance to rest the longest. And so could you think of some examples, Ishtar?
Sure. One of the most powerful campaigns has been using older persons who themselves are personalities, local celebrities. So there have been campaigns with an internationally known comedian and actor, who's Jamaican, with a radio personality who has also emceed various public events. And they've done tag-teamed television ad campaign about how to stay safe when you need to stay away from your family members, and it's hard not to see the grandchildren. It's hard not to go to the grocery, but here's what you can do instead. And they're talking to each other. You know, are you doing your exercise? Are you making sure that you're sweating? Are you making sure that you're not paying attention to all of these false calls from people who could be trying to scam you? And it's all in patois, and the messaging is therefore very effective. So that's one of the main things that's been used. It's really using older persons who are celebrities and local personalities.
And I know also Elizabeth is also Schroeder Butterfield, who's also working in the same project as Nathan. So if either of you wants to take the answer, that would be great. But if got any thoughts based on your work on Indonesia?
Did you want to answer that, Elizabeth?
Well, I was sort of thinking, just following immediately on what Ishtar was saying, that the sort of use of humor and older people that you sort of wrote about, Nathan, in your blog. So again, a sort of a humorous way of kind of trying to diffuse the situation. But in terms of sort of actually facilitating people to access services beyond kind of trying to rely more on people getting their repeat prescription maybe without having to go to the hospital, I've not really come across very much that's been done yet to kind of really make sure people stay accessing healthcare services. I don't know, Nathan, whether you come across more.
No, I think a lot of the videos that I've seen, and a lot of my actually animated videos as well, they just tell people how to look after themselves, take care of themselves, and the usual, to wear masks, social distancing, and how younger people should take care of their parents or their older adults. Mm. So I think there's been a lot of that, and posters as well, speaking to younger people what they should do in relationship to their elders. So yeah.
And Almudena, from any examples from Mexico?
Yes, what we've been doing is through this staff of 1,200 women, some of them have been like also very creative. So they have produced their own videos doing exercise, for example. So we show them to the most of the elderly people, or many of them are not that savvy connecting, but we do communicate with the family. So we tell them to put the video for them. And we have also distribute, for some of the people that are alone, we have distributed cell phones. So they can also have, access not only to the cell phone, but also with data. It's cell phones with data plans. And so, yeah, there's been very creative. And I think it's been helpful for the elderly people to know that they have like the presence, the continuous presence of these women. Some of them have known them for 15 years, so it's kind of part of their family, and they know they are available and reachable. And and a lot of the reports that we have received from the staff is that, of course, a lot of time is just about talking on the telephone, just saying, how do you feel and what do you need? Everything's okay with your family. Of course, like Ishtar was saying, not with a famous artist, which I think is great. We might copy your idea. But in terms of, are you doing your exercise? Are you drinking water? What else do you need? Are you talking to your family, etc.? I think it's a permanent message that we are trying to transmit to the elderly people. However, definitely it's been a time of a lot of stress. Phone calls help. Phone calls not only from family but from the staff, because they know how to handle this situation of stress and loneliness and feeling sad. And I think one of the intentions of just working in this group of people with all of you and Peter, it's precisely to have a better documentation of the effects in terms of emotional well-being during the pandemic. The follow-up has done some of it, but not specifically, since we have the power, the personal power to raise all these questions and just document them. I think it will be one of the emphasis of the study that we have talked with Veronica here in Mexico City, that I think it will be very useful to know a little bit more about what are the effects, not only right now, but after 8 months. It's been it's been very draining also for the people, unfortunately.
Absolutely. And Zia, from your global perspective, do you have some examples, or if not a comment?
Sure, I think country examples are the most important, but I think the element of fear and addressing it is extremely important. As we've just discussed, it creates a vicious cycle where caregiving is not accepted from the outside. Then the family caregiver has additional burden, and also providers go bankrupt, and after the pandemic, there are no other sources of caregiving. I think so. WHO discusses fear in the terms of a few areas, and one is the source of fear usually is because of an information void, where there is uncertainty. So as Ishtar mentioned, effective ways to communicate the situation on how to mitigate infection coming in and coming out, how to protect yourself, how to access healthcare, how to communicate better with your family. I think this information void needs to be filled out. I don't know the right English word, but filled out so that the void is gone. And so the older person, as well as the family caregiver, know what to do. Usually fear comes from uncertainty once again. The second aspect and what aggravates fear is, of course, wrong information. And WHO has pronounced there is another parallel pandemic, which is an infodemic of wrong information going in, of information that creates fear and aggravates the situation, especially for those who are isolated. So more and more when we discuss information and ways to communicate, Mexico City's provision of cell phones with data, I think these are will be extremely good practices that we will touch on even after the pandemic. But once again, the element fear is important. We need to reduce it. And the causes is, once again, wrong information, as well as the uncertainty coming from an information void. And hopefully countries can work to combat both in parallel to the pandemic. Thank you.
Thank you.
Can I also jump in again and say that
Sure.
based on what everybody's saying, what is striking me as well is that it needs to be ongoing and it needs to be continuously adapted. Because, for example, in Jamaica, even though the churches may be really effective avenues for getting their congregations aware of things, the churches could also be sources for spread. Because people want to go to church so much, that then these customized strategies for targeting this misinformation or the inaccurate information then needs constant attention in terms of figuring out where might be the avenues, even well-intentioned, where the misinformation or the lack of information could be coming from. So I think based on what everyone is saying too, it's important to keep in mind that these things are not static. It's like the disease itself, it's very dynamic and changing and needs a constant rejiggering.
Absolutely. And we've got a very good question from Penny Veresamso in the chat that I'm going to also bring to all of you, which is about the differences in the support available to people living in rural communities and how that's differing from the urban settings. And again, I'd like to take it to each of you. I'm aware also, I know about your work, both Ishtar and Elizabeth, with your qualitative work with carers. And I don't know if any of that, I know it's all work underway, but if you think there's anything emerging that would be helpful to also bring up. So we'll start again with, maybe we'll start with Indonesia now, given that Ishtar just spoke.
So part of the problem is that because in the more rural communities there is less good internet and less good penetration, those are actually the communities where we've got least information on, because we've not dared to go back into them. So for example, we've got in eastern Indonesia, we've got a study community, and also in Sumatra, more in the highlands of Sumatra, where we've got a study community where we just haven't gone back yet. So the information we've got from those is far more limited than what we know from Jakarta and Yogyakarta, which are very well networked. So I think in general in Indonesia, mobile phone coverage is quite good, even in rural areas, but not necessarily good enough to say sustain an interview via WhatsApp. On the other hand, we've definitely been hearing repeatedly that in the more rural areas, COVID has been less of a problem. There's been less of a spread, so people don't feel quite so kind of maybe cut off from their family members and neighbors. So there's been less disruption to the normal care practices, I would say, in the rural areas than in the sort of densely populated urban centers.
Thank you. And I'll go back to Jamaica, Ishtar.
Yeah, very similar to what Elizabeth mentioned. We have found that it's been really challenging to have internet-based communications with persons who are living in rural communities. And so in terms of figuring out care needs, we have to rely on a very diverse set of network partners. So we are making sure that we connect with the different parish officers. The parishes are the administrative units in Jamaica, and each parish has a representative from the National Council for Senior Citizens. So we connect with these officers. We also connect with not-for-profit or charitable organizations that have a reach into those communities. So we work with the Kiwanis Foundation, for example. We work with the Rotary Foundation, for example, and these entities have ears to the ground, feet on the ground, hands in these communities. And so it's really about working with these partners to say, okay, where are their needs and how can we access these people that are the most vulnerable in these communities? And often, like Elizabeth was suggesting too, sometimes their needs could be really what we see as basic needs, food, water, electricity, and how can they really adhere to COVID protocols for sanitation if they don't have running water? How can they adhere to COVID protocols for hygiene if that's not something that is typically managed in the same ways in the more densely populated urban communities? So it's really about understanding local needs and needs in those rural areas and relying on people who are there to give us information to then adapt and customize strategies.
Thank you. And I'm going to change a little bit the question for Almudena, because given that you work in Mexico City, it may not be so fair that we ask you if, because you're not working at the national level. But it was fascinating to see the data that you have and the ability and the power of this data in terms of targeting helper support when it's needed the most. And I do hope that one of the things that will change after this pandemic is that we'll see more places having this type of data available. And I was wondering whether in any other parts of Mexico, there are efforts underway to try to get this type of data infrastructure that you have developed in Mexico City, and any recommendations you may have for others who might be considering developing it in the future.
Yes. Yeah, well, the first, just a fast comment. We do have rural areas in Mexico City. Of course, Mexico City, and of course it's connected, but there's like, especially like in the south of Mexico City, we do have parts of the city that are more rural. It's urban rural, but it's more rural, and they do have difficulties in terms of IT usage, especially among elderly population. So I'm just writing on the chat, but I'll say it here. It's been more than 15 years that this database is not only a database; it's a live, registry. Has been built or has been developed, and that has proven to be very useful during the pandemic, because we do have permanent contact with the people. The staff knows not only the elderly population, but also their network of support. They know their sons, their daughters, or their neighbors. So that has been very useful, because it's not only the direct contact with the people, but also it's kind of a community neighborhood activity. The women that are in charge of this work also live in part of those communities. I mean, they are assigned to the places where they live. So it's more also about having a community relationship. It's been always useful. We have, like you were saying, Adelina, right now it's proven to be very helpful, because it allows us to communicate more effectively. And in case there's no response, we can communicate with the neighbors, we can communicate with the family, So when we set up this registry, usually people provide information about their support network, which is very useful. I think it has taken some time to build this database, but I think in terms of its usefulness, I think, I will recommend, and more like this database is more like this social register. We're moving towards, in Mexico City, towards a social registry, which is only not, the information about actual beneficiaries, but also about it's based on the household. So it's a registry, a social household registry, which means it can have a lot more information about the socioeconomic status of the family, and not only of the elderly people, and changes over time. Like, for example, right now, who is not getting any income, who is unemployed, who needs the help. That has not happened. It would have been great to happen, but yes, we're moving towards that. So I think this is one of the strongest, data information we have in Mexico City. Definitely the one that belongs to the elderly population, and it's because it's been for a long time. So I think, yes, I would recommend, and it's not only like I said, a registry of people, but it's every year there's an enormous effort to update the information, to call every one of them. I know it seems like amazing, but the Institute has the capacity to do it. So every year there's calls to the 750,000 people. every
That's
single
amazing.
year. So because there's 1,200 women that are, that's their main activity. And yes, right now we have been, I think we are, the last number last week, it's like 2,300,000 calls. I mean, it's been like 3 times, that we have called all the people, in the registry. The ones, of course, that have telephone, but also the ones that are not, they do have visits, or we call the family, So I say calls, even if they don't have all the telephone but there's many ways to reach them, and I think, yeah, it is a result of many years of building this information, and I would strongly recommend it, not only as a registry of basic socioeconomic data, but as a like a personal file for each one of the people that are here.
Thank you very much. And I can see Zia nodding enthusiastically as she listens to this, because I can, and so do you like to comment, Zia?
No, I think it's amazing what Mexico City has on in terms of data, but I think it's amazing the questions that you formulated. So I think the differentiating factor is also the calls and the number of people you contact, but also the questions that you've included are very different from what we see in other regions and countries. So thank you very much for sharing that.
And I haven't seen other questions in the chat, but I'm very happy if anybody would like to speak, for you to raise your hand, speak. I am sure also, I mean, Peter's been very quiet, and that's very unusual. And I was wondering, Peter, if you'd like to comment as well.
Suspicious, isn't it? I'm probably multitasking or doing Lego with my son. No, I'm not, I promise. I'm following the session very closely. Now, I actually, I'm going to be a little bit devil's advocate. That so far, I think the take on all of this has been very social science. It's all been about fear, stigma, isolation, the financial stresses of on households containing older people. And I could imagine a different kind of webinar, where you had a much more presence of epidemiologists, public health experts, people who are very big on infectious disease control, and they would potentially maybe look at this in a very different way. They'd say, well, let's just look at older people who are very care dependent and are very ill, and how do they relate to the more direct risks of infection, of mortality, etc., related to the pandemic. So on one hand, you might have some very severely care dependent older people who live alone. If they don't get any support from outside the household, there's no interaction, they will die anyway, fairly quickly, because their needs are not being met. So it's a brutal but tragic truth that they will just die. Then you may have people who live alone, who are very dependent, who will be getting support from outside the home, and there will be flows in and out of the home where they live, which are essential to their well-being or even their survival. And so how do we manage that? It's a bit like when we look at care homes. How do we manage that flow in and out of the home? There'll be older people who are very, very care dependent, who are living with family members. And I think we've talked a lot about older people who live on their own, who live with family members who may or may not be well looked after. But often, particularly when they're very care dependent, it'll be that kind of hospital at home situation where they will have a colostomy bag, or they will have all kinds of things going on around them. And again, there will usually, if it were not for the pandemic, there would be lots of comings and goings, especially perhaps if this person may be nearing the end of their time. There'll be relatives and family members wanting to pay their respects. There will be all of that activity taking place around them. As a kind of hospital at home kind of scenario. And so then, as an epidemiologist, I'd be saying, how do we manage the risk of infection, both coming in and out of the household and even potentially within the household? And can we look at, and again, I'm playing devil's advocate here, can we look at the protocols for long-term care facilities, and can we treat these sorts of settings? And I know this doesn't apply probably to poor older people in rural, low middle income countries, but it does apply to quite a lot of older people in particularly middle income countries, this kind of situation. Can we treat them like mini care homes? Is that what we should be doing? Should we have if not a protocol, at least some very clear ideas about what happens if the primary carer for that dependent older person within the family starts to develop suspicious symptoms of coronavirus? What happens if the older person themselves does, or somebody who comes into the household to meet some of their needs or to support the family in different ways? How should that be dealt with? And of course, within all of that, there is a question about balancing risk. So do you say to the primary carer, if you think you may have coronavirus symptoms, stay away from that extremely care-dependent older person and neglect them? Well, of course you don't. So how do you strike a sensible, practical, even ethical balance between those different kinds of threat and risk? This year, more people over the age of 60, over the age of 70 will die of non-communicable diseases than will die of infectious diseases, including coronavirus. So how do we manage the wider context of risk to mental health, to risk of dying of many other things? And I guess finally, these sorts of people, the public health experts, epidemiologists, would be saying, how do we make sure that if there is a case of coronavirus in that household, let's say the care-dependent older person, how do we make sure that the person who comes to look after them, who's visiting 20 other older people, as part of their round, isn't spreading the pandemic to them? So I think these are issues that maybe, none of us would sort of naturally engage with, but I do think that's a very big part of the story. And perhaps also even how do we relate those sorts of hard epidemiological infectious disease control kind of questions to the more social sciencey sorts of things that we've been talking about so far. So I'm not sure if that's a question or just a rather rambling comment, but hopefully it helps a bit. And I've done a lot of talking now, so there we go.
I think it's one of those comments that raises a lot of questions. And thanks for that, Peter. I mean, I'm going to reflect a little bit, if you allow me, on the sort of the high income world and what happened in terms of guidance for community care. And it came really late in almost all countries, the guidance. So the first thing first of all, they also to hospitals. Eventually, they realized that people were dying in big numbers in care homes, and they produced some care home guidance. Actually, WHO produced care home guidance very early, in fact, when there was still relatively little evidence about what this disease was all about. But most countries didn't have it until quite late on. And then, quite a while after, we started to see the first guides of infection prevention control for care at home. Now, there is always an issue of how do you reach the people who would benefit from these guides? And here we go back to the social sciences, which is where, and this is where the work, for example, that Almudena, who's had to leave us now, presented in Mexico, comes into its own. I understand, Zia, that Repro, you showed the guide, the infection control guide, and they have covered care in the community. And I wonder whether, to some extent, the lack of, so whereas it's quite easy, well, it's less easy than you think, as Peter and others have discussed previously, to find care homes in many countries, but they're much easier to find than individual families who are providing care individually, and they're much easier to reach, at least in theory. So, I mean, maybe we could have then perhaps a last round in discussing how we can provide, the protocols are out there and can be adapted, and there's the Repro one, there are others that other countries have adopted, but how can these be made available and reach the people who would be able to use them? And if you'd like to have one last round of comment, and also feel free to add any other thoughts that you think may not have come through. And just to vary a bit, we'll start with Zia.
Sure.
Sorry, I got you out.
I know this.
Can I just add a little rider to what Adelina was just saying? I think thinking about those, not just in terms of how they're communicated or targeted towards families and older people, but also towards all those health and social care professionals, yes, who will be engaging with them too. And clearly very different audiences need different kinds of things to help them do their jobs.
Yes, and if you can think of also these domestic workers that Ishtar was also mentioning, that'd be great.
So yes, I that's I think the most difficult question. I think the other difficult question you asked didn't come to me, so I was very relieved on how to progress with with rural communities and get the information to rural communities. Yes, just producing a guidance is just the very small first step, and having that trickle into each and every family member, I guess it's only through networks. And that would begin with actually local governments and authorities realizing that this needs to trickle into the families, into the roots. And that can only be done through through distributing it, not just through health workers, but through social workers, any other channel that we can think of. And once again, the literacy rate isn't that high also in many countries. And so in terms of that, providing a parallel kind of infographic so that it can complement the guidances that we have would be also an important role that government should play, so that once that information is with the family, it can be easily seen and detected and read and understood. So not a full answer, but we can work together, all of us.
Thank you, Zia. And if we now go to Indonesia, I don't know, Nathan or Elizabeth, you'd like to give us some thoughts?
You go first.
Yeah, I don't really know. I mean, I think what Zia was just saying is very correct. So it needs to sort of be picked up on by the sort of authorities. And I think once that happens, there are quite good then networks to these, because Indonesia is quite sort of organized sort of at these different layers. So it's quick and easy to get information down to the sort of village level, say, so that these healthcare visitors, for example, would be informed. I think the danger is more that a lot of this information will then go more towards the sort of fear reaction again. And I wonder whether, especially in the rural areas, the risks from COVID, and even if a household member had COVID, whether that risk wouldn't actually be a smaller risk than the risk that you then get again because the older person doesn't get their diabetes medication or their blood pressure medication. So in a country like Indonesia, where stroke mortality and morbidity, for example, is massively high, I guess worry that any kind of messaging about COVID and the dangers of COVID will then kind of deter people again from using healthcare services for almost more pressing matters. I don't know, Nathan, do you have anything more to say?
I just might add, I think it's also very important to listen to what people are experiencing and what they have to say, and understanding their comments, or both the carers and people who are being cared for. So I think there should be listening and understanding their experiences and their situation, and understanding that.
Thank you very much. And Ishtar, in Jamaica, sorry, just changing countries.
I think Peter's devil's advocate question is an interesting one, and I'll just go the other side of the devil's advocate. I think sometimes it's very easy for us to think of, here's what the epidemiologist would say, here's what the infectious disease specialist would say, here's what the social scientists say. But in Jamaica, for example, our emergency committee to deal with COVID at the governmental level, and of which we are partners and we're members, we meet every other Friday morning. It's a multidisciplinary team. And so the thinking about the questions about how do you strike a balance in terms of risk and really minimizing risk, what happens if there is an infected person in a household. The reality that we live with in Jamaica is that so many of the households, they rely on the communication via the television for the messaging about how to control risks. And then those decisions are made, as one of the persons who just wrote in the chat indicated, they're driven by government mandates in terms of how people move, where they move, who can move. And then those are also then filtered into entities like workplaces. And those formal workplaces, whether it's the bus company, etc., then has their own protocols. Then yeah, that filters into individual and household level decision making about things. Once you have the information, which has been transmitted and developed by a multidisciplinary team, what do you do? So in a situation where you know that your mother who is living with dementia cannot be in a house by herself, and you also know that the one care assistant that you have is also losing her mind because she is getting no rest, she is getting no type of help and no relief at all. How can you ensure that you're putting in systems in place that can take care of both the needs, yes, they may be hospital type needs of the person who's living with dementia, as well as the carer? And how do you then help, again, about messaging and how you communicate that message, as you're saying, Zia, with some infographics or things that are intended for large segments of the population that are of low literacy? How can you communicate to them the minimal types of conditions and hygiene and sanitation requirements that you need to have in place? Pay attention to these things. If somebody's coming in, take off the shoes at the door. Do not, change clothes, go shower immediately, and those types of practical things. So it's not one or the other. In our case, in Jamaica at least, it's really about a number of disciplinary orientations and specializations, figuring out, well, what, even if we know as medical specialists, here's where the risk is really high, how can we then transmit that information so that the people on the ground who are having to make these hard decisions, that they're doing that with the most information that they can possibly have?
Thank you. I'm going to now invite one of the people attending, MC Bretner. I'm not sure if I'm pronouncing that right as your name. I wonder if you can unmute yourself and ask the question. I hope that's possible, Lucas. If not, I can read.
I can allow them to talk. Can you repeat the name, please?
Yes, MC Bretner.
Oh, okay.
And could you also say who you are and your role?
Hi, can you hear me?
Yes, thank you.
Yeah, so my name is MC Bredner. I work for Uni Global Union. I'm the global coordinator, and we represent about 2 million healthcare workers providing direct services to clients around the world in over 100 countries. And one of the things that strikes me, I really enjoyed all of the presentations, but one of the things that strikes me is that we need to change the discourse around how we talk about workers. Workers have the information, but they don't have the resources to protect themselves and to protect their clients, residents, and patients. And so I would like, to kind of think about how we can start tying new investments to not only to patient outcomes, but to worker conditions as well. As for the most part, worker conditions mean better outcomes for patients. And I think there's an opportunity for us as advocates, as academics, to actually tie our goals together and say, it's not just about making sure that people don't die from COVID. It's also about making sure that workers aren't going to end up with PTSD, aren't going to end up with COVID themselves, and tie these outcomes together and demand more of organizations like the WHO. We talked about, yes, they put out protocols early and guidance around mask wearing, but they still said that it was kind of up to the individual, but whether or not they were going to use masks in the community. And we know that community spread is a problem. So it shouldn't be about decision making of the individual, but rather we should be making stricter protocols so individuals don't have to make those decisions, that they can follow the recommendations and that they are provided the resources by their employers to protect not only themselves but their but they're patients, residents, or clients. So I was just wondering if anyone has any ideas around investment and how we could help address this on on that type of level. Thank you very much.
Thank you, MC. And Zia, I was wondering if you'd like to come in and
Thank you very much. Of course, the advice from WHO came out several times, and the last one is from June. Because of different cultural contexts and situations, WHO can only recommend and not enforce recommendations that we have. In terms of mask, we do recommend considering using a medical mask for health workers in the community. And when we say health workers, although it is not explicitly written according to ILO, it is inclusive of social care workers as well. Also in any transmission scenario, because these recommendations have come out according to transmission scenarios for health workers or caregivers that provide home care, and when close contact is not possible, medical masks are recommended in any transmission scenario. So, however, we recognize, I think WHO does recognize that we need to do more so that we can mobilize the support and advocacy that is needed for countries to better look into occupational hazards, better look into workforce stress and address these, also to mobilize funding for these areas, once again, to address that PTSD is not a consequence of the pandemic. But yes, I think that's why we're here to discuss and progress together. And thank you very much. I forget the MC Bredner for your comment. We will work hard within and listen to the recommendation you just gave. Thank you very much.
Thank you. And with this, we're going to end the discussion. We're now going to hand over to Peter, who may want to wrap up. But from my side, I'd like to thank you all for such a
Thank you so much, Adelina. Thank you.
Thank you. And Peter, back to you.
Well, thank you, everybody. And just following on from MC's point, clearly as well, we would want to, obviously, when we talk about workers and care, there is always this complexity about paid versus unpaid workers, workers who are employees of organisations, and workers, defining that term very broadly, who are not. Workers who are professional, who are high status qualified, and those who are often working on very precarious contracts. And in fact, I sent a chat, I think it just went to the panelists, so I'll resend it a bit later to everybody, which is a paper that just came out yesterday, which was looking at nursing homes in the USA, which showed that those which made greater use of contract care workers, as opposed to people they employed on a more permanent basis, had higher rates of COVID infection. So I think there are all kinds of issues that we can bring in there. Wow, I think this has been one of our best webinars. I think there's an awful lot for people to take away from this. Certainly there is for me. There's an awful lot I want to think about over the weekend. And so I'm just incredibly grateful to, especially to Adelina, who I think has done a fantastic job of chairing this and making it work so well as a session. And of course to our speakers, because I think they each brought something really important, but also very different to our discussion. And I think made it a really interesting and rich kind of discussion. And I think often these days we go to lots of webinars and they all start to feel a little bit the same. So hopefully this webinar hasn't felt too samey and has been worth the time you've given it. We are hoping to run a webinar on the 14th. Actually, I think it's on the 13th of November. I've got the date wrong, which is the middle Friday of November. And I just got a confirmation from one speaker. This is going to be focusing on coronavirus and intergenerational justice. I'm on this Lancet commission at the moment on vulnerable groups and humanitarian issues and coronavirus. And I'm the only one who looks at old people, and most of the other people are looking at women and children and ethnic minorities. And it's been very interesting to have to look at the issue of older people and coronavirus within a much wider framework of reference. And it made me realize how increasingly what was a crisis of intergenerational relations, which existed before the pandemic, has of course become incredibly exacerbated and often is framed in terms of impossible policy decisions between schools and nursing homes, and intensifying discourse of ageism or youthism and many other things too. And of course, a crisis of secure livelihoods, fiscal pressures on providing services to different groups of people, different ages who need them. So this is going to be very much the bigger picture kind of session, but hopefully it will be very interesting. So I hope you can come along to that. If you've got any good ideas for a webinar proposal, please fill in our online form on our website, because we would be very happy for you to put something together and run it through the global platform. That's it. Thank you, everybody. Especially thank you, Adelina. Last page. Thank you, Lucas, who is the guy who basically makes this all work well, and Thais, who also provides backup. And I have to thank, of course, the University of East Anglia, because they provide some funding and allow me to give some of my time to these activities as well. Stay safe, stay well, and hope to see you soon. Goodbye.